share the
email.
slides?
Thanks. Would you like to share the slides or would you like me to? I'm good either way.
Would you share the slides for this meeting?
Absolutely. Yeah, happy to. We'll give folks another couple minutes to hop on. All right. You guys able to see that? My Teams has been a little persnickety today. Okay, good. While we wait for folks to join us, if you're a working group representative, as always, we appreciate you just dropping your name in the chat so we make sure we capture your attendance here. And we welcome any and all to this workshop and presentation. We're glad to have you. Thanks, Dave. Great to see you.
Great to see you as well.
All right. Want to be cognizant of everyone's time and a very full agenda today. So we're going to go ahead and get started. Thank you all for being here and thank you for being here on our updated time. So for those that have been part of this ride since last year, you'll note we're starting a bit earlier because we had some feedback from folks that we wanted to extend the working group time and bump the cadence to bi-monthly. So this is the first of our 2026 series. We'll be meeting for 90 minutes every other month and really look forward to you all joining us there. So thank you for your time. And we do expect some folks will join at that 4:30 mark as they leave other obligations. So thank you for your flexibility there. But with that, we're going to dive in. Our agenda today is primarily going to be a lot of updates on progress that's happened in the past 3 months since we last met as a full group. We've had a couple smaller summit sessions and other discussions since that time. And so now that we're all back together, we want to spend some time talking through looking ahead at 2026, what's the role and purpose of this working group? Where are we headed with the transformation? Dr. Pebbles will debrief our screening tool summit, which I'm really excited for folks that weren't able to join to hear more about there. We'll come back to give some updates on our overall transformation timeline. Excited to share some updates on our specialty plan procurement process. And then we'll close with some updates on renewing and adding new members to our working group representative membership before wrapping up today. So with that, we're going to go ahead and dive right in. As always, on the roll call, if you're a working group representative, we invite you to drop your name in the chat just in the interest of time. And we will also be reviewing attendance lists just to make sure we've captured everyone. So thank you all for being here. First things first, I'm really excited to welcome a few new team members to our state teams as well as our independent reviewer team. So we have a number of folks that have joined across the Health Authority, and I want to introduce them. You'll have a chance to meet them as they come present to this forum. So we're going to move quickly through this now. But in brief introduction, Jimmy Lau has joined us as a Deputy Administrator of Benefits and Delivery Systems. So he leads our benefits coverage team as well as our managed care team. And so he's working very closely on our specialty plan as well as all the new benefits that we're developing under this Children's Behavioral Health Transformation. Casey Ingres is our agency manager of federal policy and compliance. She has been part of our Medicaid team for a long time as an excellent leader of our policy work. And I'm really excited to have her in this new role, leading and supporting a lot of our settlement compliance work, along with a host of other things related to all things Medicaid more generally. I'm really excited to welcome Cassie Rolick, who is a new consultant who has joined our team. She brings a wealth of expertise on behavioral health policy from a number of other Medicaid programs across the country. And so she's really focused on helping us design our benefits with evidence-based practice and national best practice in mind. And we're really grateful to have her on the team. Carissa Pierce, you'll see a lot through this meeting. She is our new Children's Behavioral Health Stakeholder Engagement and Nevada Medicaid Tribal Liaison Lead. Carissa is stepping into the big shoes of Melorine, who I know many of you met through this forum, and she is doing a wonderful job in her first few weeks with us at the state. You may be familiar with Carissa and her work. She used to be part of the Children's Advocacy Alliance. And so this aligns really well with her strengths and convening folks to learn and really improve policy across our state. So we're really grateful to have Carissa on board. And then lastly, I want to share a few updates which are really exciting related to our independent reviewer. So over the past few months, Kelly English, you may have seen her on a number of these calls. She is a national expert who actually led the state of Massachusetts's children's behavioral health transformation just over 20 years ago when they were in a very similar settlement agreement. Since that time, she's become a national leader in these types of Olmstead provisions and settlement agreements, and has been working with our Innovations Institute team, which has conducted the technical assistance and independent review support since the beginning of our settlement agreement. Over the past few months, our teams have made a transition where Kelly will actually be formally stepping into the independent reviewer role. We're really grateful for Tim Marshall's work and leadership in the beginning of the settlement agreement, and excited for Kelly to step in as real Medicaid expert in this area, who will be supporting us through the extent of the agreement. So we're still working through the more formal change with the Department of Justice, and had a good conversation with them even this morning on that. So that's moving through kind of the legal systems, but we expect Kelly to be formally named the independent reviewer for the settlement very soon. And we're really excited for you to meet her and spend some more time with her through this work. So very timely, Kelly will actually be here. She's really wanting to better understand our landscape here in Nevada, get a chance to connect with providers and parents and youth, and really better understand our landscape as she steps into this role. So she's going to be spending a week with us in late March and early April. The first half of the week will be in Northern Nevada, and the second half will be in Southern Nevada. She will make another trip, hopefully later this year, if not early next, in our rural communities as well. So we will be spending a lot of time with Kelly across our full state. We're really thrilled to have her there. She is going to be we have a very full agenda for her, and we're excited for her to not only go on site to meet a number of behavioral health providers, but also to host a few office hours to get to meet you all. She was very disappointed not to be able to join and introduce herself tonight, but she is actually a professor of social work, and she's teaching a whole class of social work students right now. And so we're grateful for her leadership there. She will be joining us in person and for all of these future calls moving forward. And I think you'll really enjoy the chance to get to work with her. So stay tuned for more information on what those office hours will look like. Those will be located in, again, Reno and also in Las Vegas. We appreciate that many of you may not be located in those two areas. So if you're interested in meeting Kelly and having a virtual chat with her, that is very welcome as well. And we'll include her contact information when we share more info soon. So with that, we're going to move forward to review our working group priorities and goals here. So for those that have been part of this for a long time, this may be familiar, but I hope given all of the excellent new faces and voices in the mix, we want to share why are we here and what are we doing? So firstly, the goal of this working group is to offer specific advice, expert opinions, and suggestions to our state team on the policy and program changes related to our transformation. I'm really deeply committed to this work. I hope you can see how much time and thought we spend on these working group meetings, because we recognize every single change that we make in this transformation needs to be informed by the needs of our families and that of our providers and community partners. So you'll see us bring our Medicaid policy changes here. We'll talk about some of those that we brought last year, as well as operational questions related to the way our new health plan is going to roll out, and generally just open this forum as an opportunity for you all to offer suggestions, lift up the hood of a Medicaid transformation, and get your input on how we can better continue to serve folks, kids and families across our state. We also recognize each of you bring an expertise in a clinical or programmatic area or in lived experience with the way that you or a family member have navigated our healthcare system here in Nevada. And so we really appreciate that expertise, and we want to learn from it and ensure it's reflected in what we do. The last piece is we're building something really new here in Nevada, and it's something that no other state has designed in quite the same way. And so we want to make sure this health plan, this specialty plan, aligns with what you all want to see in this transformation. And so that will continue to be a key priority and focus of this group. On this working group, we have youth and families with lived experience, including advocacy organizations that represent them. We also have associations, tribal health leaders, state, county, and local government partners, as well as representation from across our state. I will share, and this is a quick preview for later, what Carissa will share, we're looking for more working group representatives that represent a range of experiences. And so if you're interested in more formally being part of this, we'd love to have you, and stay tuned for more information very soon on that. Importantly, this does align with the way that we're held to conduct this settlement. We care about this not in any way as a checkbox activity, but because we believe it's fundamental and how this process will unfold and be successful. But we also want to acknowledge this is really tied to a couple particular areas of the settlement, which I know many folks on this call are very familiar with. And so you'll see in item 77, kind of the role of this team. We have decided to hold it on a bi-monthly basis. There's some flexibility here, but we, as always, want to make it useful to you all. So we look forward to your feedback on how we can best design this working group with your input in mind. So looking back, there's been a lot of things we've covered in this working group. We've covered a lot of detail on the transformation itself, including on the settlement agreement, the way our screening and assessment system can be designed and redesigned, and detail on baseline data and our implementation plan. We've also gone deep on a lot of policy areas. So Medicaid benefits, including family peer support, psychiatric residential treatment facilities, youth peer support, respite care, care coordination. I hope it doesn't make you feel tired to look at all of this. This was a lot of content, but it's also really important things that have been reflected in changes that are already in place. So we'll talk in a second about some really exciting updates to some federal approval we've gotten in the past couple days. And I hope you all can see there the feedback we get from you is directly reflected in what we submit for approval to the federal government and for review by our independent reviewer in the Department of Justice. So I'm really excited to welcome that feedback and continue to incorporate it moving forward. And we also want to know what's most interesting to you. So in the interest of continuing to move through our discussion and a lot of items to get through, we'll save questions for the very end, but we'd welcome you to add to the chat. Are there topics or things that you're interested in covering this year? Either things that we have covered on the list that you want some updates on or have new ideas on, or something totally new entirely. We'd love to hear it. So feel free to drop that in the chat at any point throughout today or send it to our email afterwards. We'd love to reflect that in our plan for this year. With that, we're going to move forward to think about what's important in 2026. And this may also help inform things you're interested in covering here in this working group. So like I said, first and foremost, engagement with our youth, family, provider, and community partners is fundamental to every single one of these columns you'll see here. So we're excited and grateful for all the time and energy you all commit here and look forward to using that wisely as we move forward. One way we recognize we can do better and be more clear is how we have information online. So we're going to be redesigning parts of our website. We're going to include more interactive visuals and links to data dashboards, as well as meeting archives and all the information we're talking about. I recognize each of us have a million things happening in our world, and how can we better ensure that if you have questions you want to learn more about, you know where to go. So a lot more info to come on our website soon. We also want to ensure that youth and family voice is really centered in every single one of these conversations. And so we're thinking through creative ways to work with our youth and family co-leads to facilitate these discussions and more generally get input on all our policy. So we look forward to your input there. And again, teaser for a couple slides down the line in our time together this afternoon on ways to re-engage as a member more formally of this working group. Our focus for this upcoming year in the benefit side, which again, in the Medicaid world, benefits means what does our health insurance pay for, right? What are providers able to be reimbursed to deliver to recipients? We're really focused on our last two. We've gotten approval for nearly everything we're trying to do here, but we're excited to move forward with our federal approval for respite care and intensive care coordination and wraparound benefits. So a lot more info to come in this forum on how we design our policy and practice around that work. Additionally, I'm really excited for our rate reform initiatives. Teaser from exciting updates there, but there's a lot of things we have waiting with CMS to ensure that we can pay providers for the services they're doing in a way that we feel is appropriate and aligned with the work that we recognize is increasingly expensive and challenging to deliver. And so a lot of changes in increasing rates and adding quality incentives and other ways to really reflect the type of care we want to see in our community. So I'm excited for continued work on that front. On the delivery system side, this is really, in Medicaid speak, whose name is on the back of your insurance card, right? Who is paying the providers for these services? Right now, as we know, there's a range between the state's fee-for-service system and the managed care organizations that we're contracted with. What we're doing here is designing a new health plan entirely for all kids that fall within this focused population to be able to support them with the care coordination and benefits that they need. I'm also really excited. We're going to talk about this update soon. We're thinking particularly about our rural communities and how we can help our providers there with their kind of unique geographical needs in preparation for the specialty plan. So teaser of more information to come in a couple of slides, but there's going to be a lot of work specifically on our rural delivery system that I'd love this group's input on. Lastly, we recognize just because we have a new health plan doesn't mean that there's miraculously hundreds of providers joining our state overnight. And so really thinking through thoughtful and intentional development of our provider network, both of folks that are already in our state and folks that we're hoping to attract to come practice in our state where we need as well. Lastly, perhaps not as exciting, but always very important, is compliance. And so we will have through this year quarterly data reports and data dashboard updates. So you can see kind of how we're tracking kids in our focus population and the requirements in our settlement agreement to ensure that folks have all the information that they need there. There's a lot of work on the compliance front with our independent reviewer this year related to what's called quality service reviews. And these are essentially small samples of cases of kids in our state where the independent reviewer will review all the care they've gotten, what that journey has looked like, and ways we can better improve it for kids and families. So stay tuned for a lot more information to come on that. There's a lot of good detail in the settlement agreement if you're interested in the meantime, but that will be a key area of focus for us this year. So I know a lot of info, but I hope helpful to kind of get a sense of where we're really focused here in our work. So again, if there's particular topics in this category that you want to hear more about or you want to lend feedback or input on, we'd love to hear it. Feel free to drop that in the chat or send that to us over email after the meeting as well. So with that, we're going to turn to our Screening Tool Summit debrief. And Carissa, I know Dr. Pebbles is joining us from a clinical appointment. She's in clinic today, so I want to make sure she's been able to join us already. Is she on? Dr. Pebbles, are you on now? If not, we can come back to you in a second when you've been able to join.
I am not seeing her on the call right now.
No worries, no worries. Okay, we're going to keep moving. So that way we'll come back to these important slides, but I want to give a chance for her to really share her important work here. So timeline for 2026 is where we're really going to focus. I appreciate since we last met, we made a couple changes with what the timeline for our specialty plan looks like. And so we wanted to spend some good time on where are we at, where are we headed, and what does that look like? So first and foremost, this is a settlement timeline that folks have been around here may be familiar with. It is a little busy, but I think it's important for you to see. Here's all the things that we're required to do as part of the settlement agreement related to reporting, compliance, and other implementation items. So what you'll see here, that yellow box is around the quarters where we're at. The public dashboard is the big one that was published in January. That's available on our website right now if you're interested in taking a look. We're also going through a lot of quality meetings, quality assessment processes, and really thinking through the way that we escalate critical incidents to our independent reviewer. So that's all kind of key areas of focus in our yellow box frame right now. But for those that want to catch up and are interested in learning more, our dashboard again is linked on this slide, which is available on our website, as well as a draft implementation plan, which we're grateful for your feedback on. That is also posted to our website. So for those that didn't get a chance to hear that full background before, essentially our independent reviewers publish a review plan that says, here's how we're going to determine whether and how Nevada is in compliance with the settlement agreement. And then the implementation plan is the state's kind of mapping or outlining at a high level of how we will move to be compliant with each and every one of those items. So they're very well linked, and I hope helpful as you guys take a look there. So moving forward, what will the first quarter of this year look like? So this is kind of at a super high level for the next 5 years. What are we focused on? This is this quarter, what are we doing? So last month was really focused on finalizing that implementation plan and getting our new staff hired to support the transformation. This month is busy with our Screening Tool Summit, which happened last Thursday, our February working group meeting today, and then our updated specialty plan procurement, which was posted this morning. So excited for folks to learn a little bit more about that. We're going to share more in a couple of slides. March will include our site visit with Kelly, as we talked about, and an opportunity for her to spend some time with working group members. And then April, we'll have our bi-monthly working group meeting. Our quality review site visits will happen, where the independent reviewer comes to meet with some of our PRTF providers and talk through some of those cases like we mentioned. There will also be a request at our interim finance committee for funding related to some rural transformation resources that will closely align with some work we're going to talk about here too. So more info to come on that piece very soon. I hope you guys can kind of see, here's where we're headed in the next couple months. So a few very exciting updates here. First and foremost, you'll see here a list of all the things that we have submitted to CMS, our federal partners, for approval to change in the way we design our Medicaid program. Those things are called SPAs, or state plan amendments, because a state plan is our agreement with the federal government on what we can and can't pay for. So there's two big types of SPAs. One is a coverage SPA, meaning what types of benefits will Medicaid reimburse providers to deliver. The second is a rate SPA, which is how much do we pay or how do we pay for those services. So you'll see a range of those here. As you know, family and youth peer support, that was a coverage SPA. It's a new benefit to our state that was approved in September of last year, which we're so excited for. And we're working through the process to get folks enrolled and billing for that service now. The latest and greatest, green, is our rate reform SPA. Our outpatient behavioral health state plan amendment was approved last week, which is very exciting. That has been waiting with CMS since November of 2024. And I know folks on this call have been eagerly awaiting that approval, as have we. We've worked through a lot of questions with CMS and gotten approval on what we submitted, which is really exciting. So we'll talk more about that on the next slide, but want to share the celebration. It's a huge step forward for our providers in the way that we deliver care in our state, which is really exciting. You'll see there's 4 state plan amendments that are in the yellow. So things that we are still waiting for approval on from CMS. This is a pretty lengthy process typically. So it's not totally surprising, although I appreciate we're all very eager, especially for those ones back to January of last year. We want those to get approved soon. And so we're working nearly on a daily basis with CMS to work through their questions. That will look like changing the way that we pay for psychiatric residential treatment facilities, moving to a flat rate and allowing for additional add-on payments where applicable. We'll also be moving to change the reimbursement for inpatient psychiatric hospital care to be equal to that delivered at an acute hospital. So ensuring there's parity there. We have a new exciting coverage program, the first episode psychosis model, which is something that was actually developed up the street at the University of Nevada, Reno. That will be covered by Medicaid for the first time in our state. And we're again awaiting CMS approval, which will be effective back to July of last year. And then there is another new benefit, the rehabilitative residential mental health care services model. This is really a step down level of care, so not as acute as a PRTF, but it's for folks that aren't able to successfully discharge the community quite yet and need some level of support in a residential setting. So that one is also under review with CMS and has gone through a lot of public workshops and discussions over the past few months here. The last one that's gray, because we haven't yet submitted it, is the enhanced care coordination services as well as respite care. Those are ones that we're working this year in preparation to submit because those will be aligned with our specialty care plan. So very exciting news on the outpatient behavioral health rate front, a little bit more detail there. So that reflects a base rate increase for outpatient behavioral health services for kids and youth. So all of the codes, when delivered to someone that is a child or youth, will be increased by a certain amount, and that ranges depending on the service and the provider type. But the full fee schedule will be available on our website through the billing guide once our system updates are ready to go. In addition to that, there will be an add-on payment when youth receive services in rural areas of the state. There'll also be an add-on option that can be stackable if the services are provided to youth in their home. So we're trying to recognize it's expensive, and it can be more challenging to deliver these services in rural areas and in homes, but it's super important. And so we're excited to be able to offer this kind of tiered rate model and see if that can help some of our providers be able to deliver those services more easily. In that state plan amendment, we also have new rates for peer support services included. So for individual and group peer support services, that applies to adults, to youth, and to families. So we're really excited for that to be in place now, which is the other important part of our family and youth peer support package. So all of that information, all of that will be effective back to January 1st of 2025. And so a lot more detail to come on what that automatic claims recycle will look like for folks that have been delivering services that fall in these buckets during that time period. We'll be producing a web announcement that has details on exactly what that looks like, as well as a billing guide for any questions that providers may have. But just want to take a moment of celebration. This is a year and a half in the making, and we're really grateful for all of this group's input and support. I recognize there's always value in rethinking the way we pay for things. And so we look forward to your feedback as this comes into place. So thank you for that. Yes, thanks, Dave, for the applause. Grateful for you. All right, so want to provide a couple updates on our specialty plan. So as you all saw, I know the slide is busy, so I'll stay here. As you saw over email last month, we've made a few decisions to shift the way that we're designing the specialty plan based on feedback we've gotten from our independent reviewer, from CMS, and as well as from you all. And so what that change looks like is reflected in a procurement that was posted this morning. So it's available online now. And it's for a very similar model that was available in our first procurement cycle. So it's a specialty health plan that covers all medical and behavioral health services for kids. It meets the settlement requirements regarding care coordination and a lot of detail on how to design a health plan that looks and feels very specific to serve this population. The couple changes that we've made are, one, there's a new go live date, and two, there's a new geographic scope. So what we've done is we've pushed the go live date from January 1st of 2027 to July 1st of 2027. That's in part to reflect the change in this procurement process, but also to acknowledge, because we're doing something new and innovative, it means that we have to get a lot of different federal approvals, and that can take some time. And so in conversations with our CMS partners who have been really helpful through this process, we want to make sure they have time to review what we're asking and grant us that approval. So we're pushing this back for about 6 months until July 1st of 2027. When that goes live, it will be specific to the urban Washoe and Clark counties. This is very similar to how we've done our mainstream Medicaid managed care program, in which we really piloted it in the urban areas while we worked to develop our rural networks, and then we expanded it statewide. And so we're doing something pretty similar here. It will be, again, urban for the first 18 months, and the plan will have to be scaled statewide by January 1st of 2030. And we're giving folks an option for bidders to expand earlier statewide, as early as January 1st of 2029, if they so choose. So there'll be a little bit of flexibility there. But we recognize, while we will focus this delivery system change on our urban Washoe and Clark counties, that is not to say, well, we won't be making any changes in the rural areas. So what you'll see us going to our legislative body to ask for additional support on is an enhanced model of care in our rural areas for folks that are either served by our fee-for-service program or by our standard Medicaid managed care program. It will look like more robust care coordination, and also better support for providers in those areas to develop their abilities to meet those settlement agreement requirements and the specialty plan requirements in hopes of having a more robust network of providers in preparation for the expansion of the specialty plan. So this is, as I mentioned before, was going to be a really important focus of our work in 2026 with our working group. We want your feedback, particularly folks on this call, and I'm seeing many familiar faces that come to us from our rural and frontier counties across the state. We want to ensure that the way we're designing this program really aligns with what you want to see and the way that rolls out. And so we recognize there's a lot of big changes happening in our rural areas right now with the transition to standard Medicaid managed care, and also the exciting new federal program on the Rural Health Transformation Grant side. And so as those changes are taking place, we want to take some extra time to really hear from our communities on how best to design this. So I hope this timeline is helpful to really lay out where we're headed here. Again, all of those materials are available on our Nevada ePro website, which is where all procurements happen. Even if you're not a bidder, you can go on and look as a member of the public at that scope of work, at the RFP, at the technical proposal questions that we're asking bidders to answer. So that process, to lift up the hood a little bit, what that timeline looks like. Again, the RFP was posted today. Responses will be due on May 1st. They'll be evaluated by a multidisciplinary team of people from Medicaid, from other state partners, from county partners, from community providers and other advocacy groups that will be reviewing that RFP. They will be assessing it based on very specific technical proposal and feedback, and the contract will be awarded this summer pending CMS and other state approvals. So through this summer, through next summer, we'll be really focused on readiness with our providers and our members and ensuring that we have a ramp up time for something that's very new and innovative. And that's where this group will be incredibly helpful as well. During that time, we'll also be thinking through what a procurement for additional support on our rural network may look like. And so a lot more detail to come as we think through with this group on what that will look like, but know that that will go live and happen at the same time, whatever model that looks like, on July 1st of 2027. So I'll pause there. I know that's a lot of information. Before we open it up for questions, Carissa, has Dr. Pebbles been able to join us yet, or should we go ahead and keep moving on to the renewal piece?
Dr. Pebbles has joined us.
Wonderful. Thanks, Dr. Pebbles. It's great to see you. So I'm going to move to our screening tool discussion here. And so I'll turn over to Dr. Pebbles. And then once we conclude, again, we'll open it up for questions on anything and everything we've talked about today. So feel free to drop them in the chat if you want to get them down on paper now, or you're welcome to come share those at the end during our question and answer period. So with that, I'll turn it over to you, Dr. Pebbles.
Good afternoon, everyone. Sorry for that delay. I appreciate you attending today. We just wanted to go over a brief overview of the Screening Tool Summit and what we learned and some of the upcoming events that are going on. So let's go to the next slide. So this is kind of the debrief, and just tells you a little bit about how we prepared for the summit. So initially we sent out a survey just to gather some information as to what kind of tools everyone was currently using, what tools might have been utilized in the past in different environments, and then of course availability based on everyone's schedule, as it tends to be pretty chaotic for everyone working in the mental health field. So we ended up asking all of that information and then found a day that was mutually beneficial for everyone as best as we could. And then what we actually went over in the Screening Tool Summit, we did kind of a deep dive on the settlement requirements because it can be a little confusing. So going over what we were looking at, in particular, what was requested by the Department of Justice. We went over some potential tools and a list of options. I sent that out earlier this week. I had some technical difficulties during the summit and was unable to share those very lengthy spreadsheets. So we sent those out earlier along with Carissa's help. We had a checklist just so you're aware of what kind of things we were looking for in those tools so we can narrow that down. We went through a hypothetical case scenario in order to just test three in particular, general screening tools to see if the scores that we all received were somewhat similar. A lot of the tools are validated, meaning they're research-based, but we wanted to make sure that they're applicable to our situations here in Nevada. And so that was the point behind that hypothetical patient case. We used some sample algorithms just to kind of show when screening would be required and in what environments that would be. And then we had some discussions about potential roadblocks that everybody sees in going forward with these screening tools, some kind of concerns, some kind of points that we felt as very valuable in going forward with this plan, and then talking about implementation and what we're looking at, and then some other concerns. So this is kind of the checklist that we went over briefly in the summit about what exactly we're looking for in regards to these tools and if they qualify as laid out in the Department of Justice. So just really brief, and I said in the summit that can be somewhat subjective in nature, depending upon what your idea of brief is. For me, it's 10 minutes or less, 5 minutes or less is always best. So brief, mental health specific, developmentally appropriate. So if this tool is utilized for a 14-year-old, can it also be used for a 5-year-old? And then making sure that it's validated, making sure it's research-based, someone has tested it to see that it's actually going to be functional in different kind of cases. And then let's move to the next slide. And so this is kind of what's required per the DOJ settlement. So the specific verbiage states that the state will adopt a set of behavioral health screening tools that are nationally recognized or, like we said, validated, that are brief, mental health specific, and developmentally appropriate. So that was in the checklist that we just went over. And just to kind of see how things overlap, children eligible for Medicaid will be part of this. So they'll be required to have periodic screenings throughout the state. The school often already implements this and does it in fall, spring, in winter. And then if the screening comes out positive, there'll be a further assessment needed for that particular child. If the child is entering different environments, so depending upon where they're presenting, whether that's in an emergency welfare clinic, if that's with juvenile detention, there'll be some kind of standard for screening that's required. For the general public, there'll be options to go through a state phone line or a state website in order to get referred for assessments and referred for screening. And then if the screening in the system care setting or the one initiated by phone or on the website indicates that there's a need for further assessment, so there's something going on that we need to address, children that are not eligible for Medicaid will be referred for an assessment after that. So the biggest question was, when will we have to do this? Is this mandatory? Where should this occur? So just to give you a quick kind of synopsis, if the child is receiving healthcare services, so well child visits, early prevention visits, periodic screening will be required. And when we talk about screening, we talk about general screening. So a really wide net that tells us who needs screening. From that point, if we see that there's something concerning in the scores that we're getting, then that can go on to targeted screening. So just to give you an idea briefly, if anyone has used the screening tool called a PSC-17, so it's a pediatric screening checklist consisting of 17 questions, it's very general in nature. It goes over depression, anxiety, possible developmental delay, possible mood disorders, suicidal thoughts, things of that nature. If we find that there's a score on there that's concerning, we can then go to a targeted screener. So if we're concerned about depression, we can then do a screener just for depression. So that's the purpose of that. If the child is engaged in any kind of state or county system, they would need to be screened. So if they receive any services through developmental services, if they're in the child welfare system, the child welfare shelter, such as Child Haven in Las Vegas, if they're part of juvenile justice, including detention and parole, they'll need to be screened. And so those are the areas that screening is required or mandatory, for lack of a better term. And then this is kind of just a really high view. So 10,000 foot view of what we would like to occur. So this is kind of tentative, of course, based on what the end results are, but this is just a sample screening path. So if we have an 11-year-old, that 11-year-old presents with some behavioral health concerns, they have concerning signs and symptoms, they have difficulty functioning, we should implement a screening tool. So we should do a screening tool. A lot of the screening tools that we discuss in the summit are relatively easy. They don't require a lot of training. They're very intuitive in nature, meaning very easy to figure out if you've never seen it before. So we should implement one of those screening tools and see exactly what's going on. If the score is high, like I said, and there's a concern, we can move to a targeted screener, and that's up to whomever is screening at the time and the needs and the presentation of that child. Then we have to go on and say, from that screener, is the score consistent with mild kind of illnesses and signs, moderate, severe? And then we have to ask ourselves, is that child a danger to themselves or others? Because that can definitely present no matter if it's mild or severe. If they are, that of course leads us to a different path. So as you can see from this, if they're not a danger to themselves or others, that really would signify more of a standard or an urgent kind of assessment need. And then there's the option to either have a clinical assessment, and we'll talk about that later at a different summit as to what that entails. That usually is done by a QMHA, which is a qualified mental health associate, or someone that's trained to do that. That's more of a history, kind of finding out functions, strengths, anything that we can assist with. If the child is a danger to themselves or others, that's emergency. So we skip that clinical assessment and we go immediately to a comprehensive assessment. If they present in an emergency type situation, we can skip the screener and go directly to the comprehensive assessment. So please don't think that the screener is necessary before we move on to do that. And that comprehensive assessment is done by a qualified mental health professional, such as myself, or a therapist or a psychologist, just to give you kind of an overview. And again, if you'll see down there in italics, it says immediate comprehensive assessment is required when it's mobile crisis that's responding. If the child presents in an ER, at a psych hospital or residential psychiatric facility, if they're released from juvenile detention or youth parole, or if they've been in a child welfare emergency shelter for more than 7 days. That's when a comprehensive assessment is needed. And of course, this will be delineated later with algorithms and kind of pathways to make it a little less complicated than it probably seems as me explaining it today. And then let's move to the next slide. And so this is just a brief overview of what we learned. And again, we're greatly appreciative that you took the time to join us for the summit. We really, really, truly, honestly value your feedback. And so what we heard were some concerns, and they were similar to that of which I've heard from speaking to all of the people throughout the state. Changes to the current tools, right? No one wants to do anything new. If they have a process that's currently working, our intent is not to disrupt that. We don't want to take something away that's already functional. We just want to make sure that whatever tool is utilized meets that DLJ requirement. No one wants to change to some different policy or procedure because we all know that takes quite a lot of time in order to implement and to understand and learn. So we did hear about that concern. We also heard about privacy. Honestly, I completely understand having the ability to opt out for parents if you don't want your child to be screened, the time needed to screen. I completely understand that, which is why I was a little late today. It's always chaotic in the psychiatric world, so we always worry about time needed to screen and cost of that screening, right? So that could be human resources, that could be implementing hardware, software, things of that nature, and training, of course, right? But that's why we really want to choose something that is intuitive, and we don't need a lot of training in order to complete. We heard about the increase in positive screenings and the fear that that would mean more referrals, right? And we don't have a lot of professionals that are available to treat the pediatric population. So we heard that loud and clear. And that is something that we're concerned about as well. And of course, working on. And then we discussed the deadline regarding children in child welfare shelters of that screening getting done when they're in that shelter for under 7 days. And so this is something obviously we'll bring to those on the team to make sure that we're really considering everyone in the workforce available and the constraints that you have. And then observations that we've noticed, schools, like I said, are already doing periodic screenings 3 times a year. They're using some screening tools in order to help with interventions within the school system and then referring out if needed. A lot of counties already are using these generalized tools, and those are some of the tools that are currently being utilized that are listed. We also learned some information from another state. We definitely don't want to reinvent the wheel. We want to make sure that we're doing everything possible and we're implementing things that are feasible and realistic. Washington State uses a PALS line. So that's a line that providers, pediatricians, primary care can call. I always say it's called phone a friend is what they should call it. So basically they can call and talk to someone with psychiatric training and say, I don't know what to do. I'm in a primary care office. Can you help me with this particular situation? And let me know what meds do I start? What screening do I do? How quickly does that child need to be sent out? Washington does that. We do have a PALS line available in the state, and we've had an increase in funding for that. So that's exciting. But in Washington State, that PALS line also works as a referral center. So not only do they assist with consults, but they also coordinate referrals, and it's based on regions. So we're looking at things like that as well, just to make sure we take in all kind of options and circumstances. And then right now, what happens, which is the biggest question, of course, we have to have discussion with our wonderful county and state partners just to find out how we can work together and eliminate those silos that I kept hearing about in the care. And then we have discussion. So once we determine a set of tools, we have to then bring that set to several different entities. So CMS, the Center for Medicaid and Medicare, or the opposite way around, Department of Justice, the state, and then we have an independent reviewer that has experience with implementing things like this in multiple states, and then they make that final determination. So we did send out a survey along with all of that wonderful information, the exciting spreadsheets from the summit, just to see what your votes are as far as a set of tools is concerned. That will be open until the 20th of this month, and that was sent out. If for whatever reason you don't have that link, please feel free to reach out to us. I'm happy to send it to you. I want to make sure everyone has a voice and an ability to make that decision and vote on that. And then we'll have a final vote, and that will close 6 days after that. And then we bring that information on whatever you voted for to those other entities. So happy to help with that or discuss anything that might be a little confusing from today. Just feel free to reach out to do that. And then, of course, we'll discuss the further levels, so the clinical assessment later on in another summit, likely in the spring.
Wonderful. Well, Dr. Pebbles, we're so grateful for you, firstly, juggling all the things, and secondly, for really presenting this in such a clear way for us to understand all the different steps. So I appreciate you, and I'm really grateful for everyone's input and feedback, and what was an excellent discussion. I think we had nearly 100 providers join us for that. So thank you again for spending your Thursday night with us, and we look forward to some follow-up conversations there. So again, any questions that you have for Dr. Pebbles, feel free to drop those in the chat or save those for our Q&A at the end. But now I'm excited to turn my slides forward, just a couple slides, pardon the moving quickly here. I'm excited to turn over to my colleague Carissa, who will be sharing a little bit more about how we're refreshing our working group membership. So Carissa, I'll turn it over to you.
Thank you, Anne. Hello, everyone. It is really exciting to be here joining you tonight. My name is Carissa. I see a lot of familiar faces and names from my previous work with Children's Advocacy Alliance, and so it's really great to be in this space again, working with you in a new capacity for children's mental and behavioral health in Nevada. So with the new year and the new structure to the working group meetings, we wanted to provide an opportunity for new folks to join the working group and to also allow our existing working group representatives to renew their status if they would like to. So for anyone who is interested in being a representative of the working group who's not currently a representative, we want to hear from you. We're huge on having feedback, and this group is such an amazing opportunity for that. We included this list, and Anne touched on it a little bit previously, of the folks that we think would be really great representatives for the group. So this includes youth who have experienced one or more of Nevada's systems of care, parents and caregivers of all kind of youth who have experienced that, or any type of system for Nevada's behavioral health. Where we'd love to have advocacy groups who represent youth with experience, and behavioral health providers, or really providers of medical services at all levels and types of care, because we know that behavioral health can be seen across the board for all types of medical care. We'd love to see some applications from provider organizations or associations. I know Anne touched on this too, but our tribal health providers and advocates for both rural and urban tribes, we would love to have some representation there. At our summit, we had a lot of school health leaders representing, and that was amazing. So we appreciate all of your engagement. And we'd love to also invite our county partners and state agencies. Really, our goal and what we value is representation across the state in all types of interactions with Nevada's behavioral health programs for children. So we would love for you to consider applying to represent the working group. In alignment with our earlier slides on the purpose of the working group, we really want this to be a collaborative space where everyone can share feedback on what changes are happening to Medicaid and help shape the direction of our new programs for children's behavioral health. So as a reminder, our new format for the working group meetings is every other month for 90 minutes rather than every month for 60 minutes. And the date is the same, so it's still going to be the second Thursday of every month, starting at 4 p.m. So for 2026, and recognizing that we have some changes and a new format, we also want to be inviting our working group members to engage with Medicaid in one-on-one and small group settings where we can discuss interest topics for children's behavioral health that may or may not be a topic of discussion for the larger group. So this is where we might get really granular about things that are impacting specific provider types or within schools, or looking for some specific feedback from youth. And so that's a really great opportunity for people who want that deeper level of engagement. So if you're interested in applying, or you know someone who would be a great fit, we have opened an application form for you to submit. We would ask that anybody who's interested, please submit your application by Friday, March 13th, which will allow us some time to review applications and inform people of their working group status. So for existing working group members as well, we did send out a separate form yesterday where you can indicate whether you'd like to continue as a representative or not. I want to give a huge, huge thank you to everyone who has been a representative up to this point. Y'all have been providing some tremendous feedback, and we really appreciate the opportunity to collaborate and learn with you. And we'd love to have you continue. So we have a separate form that is a little bit shorter than that new application. So if you didn't receive that, please reach out and we'll send that to you. So on this slide, we're looking at a timeline, looking ahead for 2026 so we can visualize some of these dates that are happening. Starting with February, we had that amazing screening tool summit on the 5th. So thank you to everyone who attended and to Dr. Pebbles for leading us and giving that really cool overview of the debrief from the summit. Today, February 12th, is our working group meeting, yay, and also the day that our working group application forms are open. Moving into March, our first interesting date is Friday the 13th, which is fun because tomorrow is also Friday the 13th. So shout out to a double Friday the 13th. The working group renewal form and the new applications are due that date. So we have it circled in that yellow marking. As a heads up for our timeline with the applicants, we're planning to spend the following week and like on a rolling review of the applications, but really digging into them that following week, the 16th and the 20th. And then we'll be informing folks on the working group status the week after that, the 23rd through the 27th. We briefly mentioned earlier, but we're having Kelly English, our independent reviewer, join us in Nevada on the week of March 30th through April 3rd. So this is a really exciting opportunity for all of you to engage with her. We're setting up these office hours, which will be an in-person opportunity in both Northern and Southern Nevada for you to provide feedback on how things are going. We're still shaping what that looks like. So as we have agendas and solid times and locations, we will be sending out information through our listserv and to the working group members so that you can all be a part of that if you're interested in engaging. Finally, for April, we are having our April working group meeting on the 9th. That's from 4 to 5:30 p.m. And then we'll be having a quality review site visit that we briefly mentioned earlier, and we'll also be providing more information between now and then as we are developing that timeline and schedule for that visit. And then what that looks like in terms of engagement and who we might be reaching out to engage with. Moving into our wrap up.
Actually, Carissa, before we do, I'm wondering, since we've had so much good info, before we move to wrap up, because we have some exciting updates that I want Carissa to share there, I may actually stop sharing my screen here and open it up for some questions and comments. So before, we will have a formal comment period, a public comment period at the end, but while the information is fresh in your minds, if you have questions on the working group purpose, goals here, the settlement timeline, specialty plan updates, or the screening tool, or becoming a working group representative, we'd love to hear it. So any and all topics we'd welcome, and then we'll turn to our final wrap up and close, but we want to give folks a chance to chime in with any questions while it's still top of mind. So feel free to raise your hand, come off mute, or drop a question in the chat, but happy to answer anything that's top of mind. There's no way I just answered all of your questions. There's got to be more. Well, we'll let folks keep thinking, but I'm hopeful that all of this information has then been helpful to answer a lot of questions that I know have been top of mind. So I will flag, I know, Carissa, you have a couple final updates and kind of some good newsy notes from a couple of our sister agencies, so maybe I'll share there. Chris, great question to lead us into the next section. So let me share my screen with that wrap-up slide, and Chris, if you want to give those updates, we can drop that form in the chat for folks as well. I saw a comment that maybe some of the links aren't working, so we'll make sure you have access to that. So Carissa, I'll turn it back over to you.
Thank you. I was grabbing that link to put it in the chat and couldn't do everything at once. So thank you so much, Anne. I was on a roll, so I'm glad you paused so that we could have some time for questions. And please continue putting them in. We'll also hang out. So if they come up in the next few minutes that we'll be here. Our next meeting is on Thursday, April 9th from 4 to 5:30 p.m. And then just as another reminder of the big things we have coming up, we're really excited for Kelly to come and visit with us. We're putting together a really cool agenda for showcasing different sites to her. It'll be pretty interactive with the community and different behavioral health groups. And then like we mentioned, we're looking into how we can have office hours where you can all meet her and provide feedback. So we're excited to be sharing more and reaching out to you about that. And then we have this form for the working group, and I just sent that in the chat as well. So please go ahead and fill that out, and then we'll send out a reminder for the due date so that in case you forget between now and March, you'll be able to have that reminder.
Right. Chris, are you able to click that link in the chat there? Is that working for you? I just want to make sure that you have access. Perfect. Wonderful. Glad to hear seeing it works. Natalie, yes, we would love to have Kelly connect with you. So we'll follow up with more information. And we welcome any and all providers, community partners, family members. It will be an open invitation to chat with Kelly. So we look forward to those conversations. Thanks for making yourself available in what I know is a busy schedule. Right.
Awesome.
Some newsy notes, Carissa, I'll turn it back to you.
Thank you. So we have 2 upcoming opportunities that we wanted to highlight for everybody. The one on the left, that form or that picture is with the Aging and Disability Services Division. They have an opportunity for folks to join the Nevada Capacity Building Institute, which is geared toward improving service outcomes for people with intellectual and developmental disabilities and complex mental health or behavioral needs. So this opportunity is designed for all levels of staff and professionals who are looking to improve their knowledge and skills working with these populations. The application deadline for the 2026 cohort is February 16th. So there's not too many days left to fill that one out, but we will send out the information for it in a follow-up email, and we'll try to get that to you as soon as possible. The second opportunity on the right is for a series of specialized trainings that will be hosted by the Division of Child and Family Services System of Care. These trainings are open to licensed or licensed eligible clinicians who are Nevada residents and graduate students who are enrolled in a Nevada institution who are actively seeing children and youth. So it is more of the narrow population or focus for this one. And there is an interest in eligibility service because of that limited capacity for it. So that deadline is March 13th. So a good day for deadlines, it sounds like, for this and also our working group form. And I will send the information for that in the follow-up meeting as well. So if you're interested in either of those, you will receive more information, more details on it soon. I know I'm giving a pretty vague overview, but they seem like some really cool opportunities.
Thank you. Wonderful. Thank you, Carissa. So as always, we'll now open it up for public comment. Please, again, state your name and chat in the chat or verbally if you're chiming in, so that way we can take that down for a record. But I'm seeing a question here in the chat from Ellsworth. Does review of school records, which must be requested and assembled, occur at the comprehensive assessment stage? If so, is there any screening tool which would trigger records requests? I have in mind the fact that intellectual assessments are time-consuming and may often have been completed as part of special education assessment. Great question, Ellsworth. I look forward to if Dr. Pebbles has any input on this she wants to add. I will note the guiding principle for screening tool and assessment work as we move through this transformation is to try to have as few kind of rescreens or reassessments as possible. We recognize that it can be quite not only time consuming, but traumatizing and challenging for kids to have to retell their story over and over. And so the intent is to be as collaborative as possible and pull information in from other assessments so we don't have to redo them. So it's a great question about whether the screening tool would trigger records requests. And I think that's something we should think through as part of our process. But Dr. Pebbles, anything you want to know on that front? And that may be a good conversation that we could have with some of our partners from the school settings as well.
To my knowledge, I don't think there's a particular screening tool that would trigger that. And I can tell you as a practicing provider, I haven't ever requested school records. Most of the time I just request the history and try to get a roundabout assessment of what has occurred. It would be helpful, but I have never done it myself. And so, but that is definitely something that we'll discuss in the future elsewhere, just to make sure that we're addressing your question appropriately.
Absolutely. Seeing one more question in the chat, and then Karen, I'll turn to you. Michael, your question was Medicaid rebill of services back to 1/1/2025. Yes, that is correct. What's what in our Medicaid world we call a recycle, a claims recycle. So it's an automatic process to recycle the claims that were submitted during that time period for the codes that have that new payment rate. So we'll have more information in the web announcement, but it will be back to 1/1/2025. So thanks for checking. All right, Karen, good to see you.
Hello. Hey, has there been any consideration with the screenings to allow youth that have already been diagnosed, maybe already had hospitalizations, to opt out of the screening? And here's why. We have families who have told us that just by virtue of a screening happening at school, the youth come home and say, are you sending me to the hospital again? Because the school asked me all those same questions again. So is there any contemplation of how to deal with that?
Yeah, it's a really good flag, Karen, and I look forward to Dr. Pablo's thoughts as well. We haven't had formal contemplation of an opt-out from, for example, the EPSDT guidance, but I think what we will include in our Medicaid policy, we have a whole section on EPSDT, would be this request and recommendation that providers include this screening, but it's really up to their clinical decision, right? And so if that school health provider that's doing it, or a pediatrician, or whoever is conducting that EPSDT visit, is aware of that child's history and recognizes that may not be an appropriate setting to have this conversation or needed, that could be a clinical decision they make. And I don't, would be something that we could reflect in our kind of write-up. It wouldn't be a requirement, right? That's really up to that clinical decision maker to make that call. But I wonder if there's ways we can almost formally note that, because I think you're right. We don't want to be re-traumatizing by doing it. And we also want to catch if there's escalations of need. And so I think we need to really sort through what feels best for kids and families through that. So I'd love your thoughts on whether how formal or not to make that. But Dr. Pablos, feel free to chime in if you have other thoughts there too.
Yeah, I've heard that, and I've heard sometimes when a screening is done, and particularly those targeted at suicidal ideation, oftentimes it's almost suggestive in nature. And so the kids, say yes, and they endorse some of the signs and symptoms when in reality, there's really no severity. So I can say, as a practitioner myself, when I screen, there's sometimes, even if there's a previous diagnosis where it doesn't quite line up, and I do still screen in some events just to make sure that we're not missing anything. But kind of like Anne said, we're trying to make sure that we concentrate on the least amount of re-traumatization of the kids, being able to, have their privacy, but also making sure that we're being safe while keeping respect for them, right? So there are some times when unfortunately we do have to ask the same question. We do have to reassess just to make sure that we're not missing anything. And it's quite often, I'll be completely honest, that occurs. But I appreciate that feedback from the parents, because we do want to make sure that we're taking their thoughts and their feelings into consideration.
Yeah, absolutely.
Thank you.
Yeah, I'm glad it's helpful, Karen, but I think this is a good thing for us to take back as we work on that policy. Once the screening tool set is selected, and we'll be reflecting that in our EPSDT policy, we can add something in there that really notes how that is a part of a clinical determination or their choice as a practitioner, and to really maybe even trigger that thought for folks that may not have thought about that already. So I really appreciate you raising that, and look forward to your input on that exact language as we get there in the process.
That would be great, because often parents are having to calm the youth down after doing a screening because they think they're going to have to go to the psychiatrist, or they're going to have to be hospitalized, and they don't want to be hospitalized. And so it becomes an issue, especially for kids that also have other diagnoses.
Absolutely. That's great.
And I
feedback,
just wanted to say really briefly, if that's okay, that,
Please.
this is something that I talk about on a regular basis with the kids that I treat, is that when we're talking about something like depression in particular, right, there is always a degree of kind of the thoughts of suicidal ideation, right? Those kind of thoughts of, this is a lot for me to handle, I no longer want to do this kind of thing. And they vary. It's on a scale. Sometimes it's a 10, sometimes it's a 0. Sometimes it's really easy for the child to kind of distract themselves or to use tools that they've learned in order to kind of combat that. And sometimes it's not. I will say that lest less panic, for lack of a better way, from the psychiatric standpoint when someone tells us that there's suicidal ideation, because it doesn't necessarily always point to a lack of safety. It just points for us to acuity level of what's going on and if the treatment that's currently happening is actually effective. So, but that takes education, to be completely honest, Karen, of providers and parents saying, yeah, we're talking about suicidal ideation. Yes, it's scary, but it doesn't automatically mean that you have to be rehospitalized. I look at it from a different perspective as a provider of that I need to change my treatment plan. I need to reevaluate. If you're having something like suicidal ideation on a regular basis, then something we're doing is not effective enough. But I can see how it would be concerning for kids, right? Because that's always the fear, even when I'm talking to people, is they don't really want to tell me some things. Most of the time it centers around psychosis and hallucinations that they don't want to divulge because they feel like we're going to lock them up, right? But it's like, we just need to know. I tell the kids that I treat, I can't break your brain open and see what's going on. If you have strep throat, I can run a strep test. If you have a fracture, I can run some imaging. I can't do that with psychiatry. And so it's not necessarily objective. And we have to go off of what's being told to us and what we see. But I can see how that's scary. And so I appreciate that. And that'll help me later on as a practitioner to kind of reevaluate what I say and how I educate the kids and the families. So I appreciate that, Karen.
Thank you.
Great discussion. Sherilyn, seeing your hand up. Good to see you.
Good to see you too, and thank you everyone for these meetings. They've been great, very informational. Couple things. Glad you brought up the CBI. I'm in that cohort 1 right now, and it has been a great learning experience. And really, I think what's kind of coming out of our group, just to share, I think you all should apply because I think it's really awesome. We may be making policy changes and things like that. So please sign up, apply. It's been a great learning experience, a great connector. Like I have met so many people. So there's like so many bangs for your buck on this that I'm so glad you guys mentioned that because I was going to do a public comment on it, but thank you for doing that. Thirdly, the form that we can fill out to be an application as a member, when you're asking us which of the following groups do you want to represent, what if you can represent more than just one, like 3 or 4, but I can't put all those on there. It only allows you to put one. Do you want us to do multiple applications? If you feel like that's redundant or whatever, or do you just want us to select what we truly want to come to the table to represent in our working capacity or family capacity, whatever that might look like?
It's a great question, Sherilyn. I appreciate that. Carissa, do you have a preference? Maybe we can even find a way to accept multiple checks for that question, but what are your thoughts?
I was thinking the same. I can definitely open it up so you can select multiple, and then we can also, we know that a lot of people have multiple areas that they are able to represent, and that's what makes everyone so unique, is that it's not just that you're coming from one lens. So if that would be nice to have that represented, then we're more than happy to. I can go in and make that edit today, and that should be reflected. You might have to refresh if you have it open currently, but you should be able to do that. And yeah, I think that's a great idea. Thank you for that feedback.
Yeah, thank you. And thank you, Karen and Dr. Pebbles, for that awesome conversation, because I think you hit things, you said some things that are really relevant in what's happening today. So thank you.
Oh, thank you, Sherilyn. And also want to acknowledge, I'm glad to hear the CBI experience has been so positive for you. I went back to the slide for folks to see, again, plugging that for the second cohort, following in Sherilyn's footsteps. So if you're interested, Carissa will be sharing more info on that. And Sherilyn, I'm going to attend those presentations that you all will give at the end of the cohort series. So I'm really looking forward to learning from your work there too. So thank you for that.
Awesome. We look forward to presenting to you. I think it's going to be really informative for you guys.
I'm really looking forward to it. Awesome. All right, Carly, good to see you. How's it going?
Hi, Ann. Going great. Carly Murray for the record. I just wanted to, first of all, thank you for all of your work on the Screening and Assessments Summit. I love seeing how transparent Medicaid is and taking feedback throughout this process. I just wanted to make sure that feedback is taken into account on more than just choosing the tool. We've heard from a lot of parents that when their child is being screened, they don't always understand what the screening is or what it means if their child is flagged in that. And that they're really looking for clear guidance and coordinated next steps. And so as Medicaid moves through this process and develops the universal screening and assessment tools, families are really asking that it goes beyond just identification, but also outlining clear communication and meaningful follow-up as well.
Thanks, Carly. That's a great point. And you're right. This tool is only one small step in the broader component of what's the process in which it's used, what's the overall guidance, how is the data shared once it's completed, right? How are folks connected to service? So there will be a lot of more opportunity to discuss that, and we'd love your input, particularly from the parent perspective on how can we do it in a way that they are informed and aware of what resources they have, and what different types of screening results could indicate kind of action or need for. So I'm really glad you raised that. It's spot on, and it will be reflected in more conversation there, because as this rolls out, and that's something Dr. Pebbles said, I think you touched on in the summit itself, we're going to have to pilot this in smaller areas, test it, see what's working, see what's not, make changes. So really look forward to this full group's input through that process. But Dr. Pebbles, anything you want to add to that too?
No, I 100% agree. And I know that there's one tool in particular, and forgive me for my memory has failed me. My brain is full today. But I believe it's the SDQ that allows us to, and it's a general screening tool that allows us to have a baseline assessment and then allows consecutive assessments after that. So we can follow it and kind of track it, right? And so that's really what I would love to see in a tool, is one where we can kind of map things out, similar to when you go to a primary care appointment and they run labs for you, right? And you're looking at, like, let's say your white blood cell count over time. You should be able to map and see, like, okay, it was high, it was low, it was high, it was low. And then that helps us to coordinate care and say, we're noticing it's high in the spring or the fall for most kids. And then we can kind of adjust as appropriate. But yeah, I think follow-up is key, making sure that we're assessing our treatment in an objective manner so we can adjust if we need to.
Great. Thank you, Anne and Dr. Pebbles.
Yeah, thanks for great feedback. Right. Any other thoughts, questions, comments before we close today? I know it's been a lot of information, so I just want to thank you first and foremost for hanging with us. It's a lot of me talking at you, so thank you for your patience with that, but I hope it is helpful to kind of reorient to where we are in this year, where we're headed moving forward, and just want to express my deep gratitude, appreciation for all the time and insights and wisdom you guys have shared with us and helped me understand better how to move forward with this really important work. So thank you. I'm excited for this year ahead together. As always, shoot us an email if you have questions, you have feedback, you want to see something different in these forums. We want to make it useful to you, so we look forward to hearing from you. But otherwise, stay tuned for more information on the trainings, office hours with Kelly, and then our agenda for the April meeting when we'll come back together as a group. So thank you all again for your time, and have a lovely rest of your evening. Take care.